So now we're going to begin looking at how mindfulness practices can help us with a number of everyday psychological difficulties. And we're going to begin with the exhilarating and uplifting topic of working with depression. Have you ever thought about the difference between sadness and depression? We've all experienced both to some degree. How would you say they feel differently to you? When I ask mental health professionals this question, they typically come up with a variety of answers. Some say, well, depression lasts longer. But then it turns out that it's actually possible to be quite depressed for a few hours or quite sad for days, so that may not really be what distinguishes the two. Others will say, well, depression is more intense. But I've certainly had the experience of being a little depressed or very sad. Some people will say depression includes hopelessness, and that one seems to hold. Depression almost always involves this narrative about me and about my circumstance that ends with a conclusion that things are not good. The other thing that we notice is that in depression, there's a sense of deadeningness with very little joy or interest in the world. We feel as though things don't have taste to us. Things don't have meaning to us. It all feels kind of blah. We understand, on the other hand, that sadness is quite alive. It's quite vibrant. We describe it as being poignant. When we read Shakespeare and he says, "Parting is such sweet sorrow," we get what he means. If he were to say, "Parting is such sweet depression," we'd think, this guy isn't a very good writer. The key to depression here, what differentiates it from sadness, is the way it involves a kind of shutting down of the organism, closing down to try to avoid pain. Now, as it turns out, this shutting down to try to avoid pain is not unique to depression, but it plays a role in most of our psychological distress. And to understand this better, I want to tell you a story. And this is a story about the men and women who finished writing recently the DSM-5. That's the Diagnostic and Statistical Manual of the American Psychiatric Association, which is what we use to diagnose different kinds of psychological and psychiatric disorders. I heard this story from Dave Barlow. He's a leading anxiety researcher. He's at Boston University. And he's been part of the committee who's writing the section of the DSM-5 that deals with anxiety. And he says that across the board, there's been this battle raging between what he calls the lumpers and the splitters. What the splitters are saying is that what was wrong with our old system, with the DSM-4, is we did not yet have sufficient diagnostic categories. We were still lumping apples with oranges together. And what we really need are even more carefully subdivided psychiatric diagnostic categories so that we could separate all the subtle variations in disorders. And that would be useful so that we could develop standardized treatments and test them experimentally to treat the different subdisorders, as well as to develop pharmaceuticals that were targeted to particular disorders. Now, when the lumpers hear this, they tend to roll their eyes and they think, this is ridiculous. And lumpers tend to be practicing clinicians who are working with real patients. Because what the lumpers say, and what virtually all practicing clinicians say, is, you know, I virtually never met a patient or a client with a single DSM-4 diagnosis. Almost everybody had a little bit of this, with a mixture of that. They don't fit the categories so well. In fact, as a friend of mine put it, our diagnostic categories don't exactly carve nature at its joints. People are far more complex than this, and they have a little bit of this strength and a little bit of this weakness across so many different domains. Furthermore, the lumpers say, I think by subdividing so much, these different categories, you're missing the forest for the trees. Now, the splitters at that point quite naturally say, what forest? And the lumpers say, well, you're missing the universals in psychopathology. You're missing the universal things that cause people psychological distress. And the splitters say, what universals? These are separate diseases. I don't understand what you're talking about. And the lumpers say, for example, you're missing the role of experiential or emotional avoidance. And this is our tendency to want to avoid some kind of painful experience. And in the process of avoiding it, we wind up stuck in some kind of loop that keeps us trapped for a long period of time. Let's look at how this operates with a variety of problems. I just mentioned depression. Well, in depression, we'll be exploring it in a little bit more detail. It is the shutting down of emotional experience that actually gets us into trouble. But we can see this in other areas also. Let's look at how this works with a common problem like addiction. Many of you, like I, probably drink socially at least occasionally. I ask you, when you drink, do you do it exclusively for the taste? I'll sometimes ask audiences this, and there's often somebody who will raise their hand, or if I'm teaching in Marin County, a lot of people raise their hand. But most of us don't drink just for the taste. In fact, I remember when I was young and first tasted alcohol, and it didn't really taste so good. It was only once I had a conditioned association between the taste of alcohol and some positive feelings associated with inebriation that it started to become attractive. Rather, we drink because we want to change one feeling into another feeling. For example, I've come home from work, I've had a hard day, I felt kind of stressed. It would be nice to have a beer or a glass of wine out on the porch before preparing dinner. Or maybe I'm going to a party, and at that party there are going to be some people there who I don't know. Or worse, there are going to be some people there who I do know, and I think, a drink or two would make this go a lot better. So most of us, when we drink, we do it because we like the experience of going from feeling some kind of tension or difficulty to feeling some kind of relaxation. This is true with anxiety disorders as well. If I get anxious before doing public speaking, or I get anxious flying in airplanes, but I speak publicly and I fly an airplane regularly, I probably don't have an anxiety disorder. Rather, I'm just a nervous guy. If, however, I start avoiding public speaking or avoiding going in airplanes in order to not feel anxious, then I'm on my way to an anxiety disorder and bigger problems. We even see this operating in very serious problems such as psychoses. When I ask audiences of mental health professionals, what are the kinds of things that they typically observe for a person who's struggling with, let's say, schizophrenia, that might push the person over from doing pretty well to doing what we call decompensating. Decompensating means, in essence, falling apart, falling into either a state of delusion or hearing voices or having one of these psychotic manifestations. And almost always what the people say is, well, it's things like a change in job or the loss of a job, or maybe the death of somebody close, or perhaps losing housing and having to move. And all of these things are events that, when they happen to people who aren't struggling with psychosis, bring up difficult feeling. But what happens if a person's struggling with psychosis is, instead of feeling the difficult feeling, what happens is they get these psychiatric symptoms. So what we see is, across the board, there's experiential avoidance or emotional avoidance playing a role in all sorts of psychological difficulties. Basically, in all of these, it's our attempt to not feel something painful that actually trips us up and gets us caught in the disorder. What we'll see is that mindfulness practice, which is in essence a form of experiential approach to everything, can help with all of these. There's a wonderful video that's been made. It's an animated video. You can see this online. It's on YouTube. And it has a samurai warrior, and he's sitting in meditation posture. And this fly comes along and lands on his face. And he starts going like this, trying to get rid of it. And then you see him reach for his sword. And he brings the sword out, and the fly goes away, and it goes wham! And he divides the fly in two. And you see these two halves of a fly. But then what happens is the fly starts to come back to life. Crackle, crackle, crackle. It becomes a whole fly. Then you see over there, so did the other half, and now there are two flies. So he takes out his sword again, and he whacks the two flies. And now he has four flies. And this just keeps going and going and going until he's just surrounded by a swarm of flies. And it's not until he notices that it's the fighting of the fly that's causing the problem, and he's able to resume an accepting posture, that the difficulty goes away and he can release the fly and he's okay. This is what happens to us with all of these disorders. Our attempt to get rid of the symptom, to get rid of the discomfort, simply multiplies our misery. Let's get back to depression. Do you know what happens to a sine wave? Standard S-shaped wave that you might see on an oscilloscope or that you could see with a rope. If you move it so the bottom part doesn't dip as far below the midline, what happens is the top part comes down too, okay? It doesn't rise as far. This seems to be what's happening in depression. The mind tries, consciously or unconsciously, to avoid the bottom part of the sine wave, to get rid of the pain. And in the process, we lose the capacity for joy, for interest, for engagement. We become deadened. We lose the capacity for life. So depression involves shutting down and turning away from pain, while mindfulness turns toward the experience at hand, and in so doing, it challenges the depressive stance. And that's why mindfulness can help us so much with depression. Let's look at we'll look at just a couple of the dominant models for understanding depression, and you can see how mindfulness can help if we understand depression in these lines. Marty Seligman was a leading psychologist, and he came up with an animal model for studying depression. And the experiment it's a little bit cruel, but it wasn't actually harmful to the animals. What they did was they constructed these large rectangular cages in which they could put a dog. And the cage had the option of having a barrier put up. And it had a floor that could be electrified on either side, or both sides. And the electrification wouldn't harm the dog in any way, but it was uncomfortable. It was distressing for the dog. So here's what they did. They took the dog and they put it on one side of the cage, and they applied an electric shock, and the dogs would always jump up and go to the other side that wasn't electrified at this point, and they'd feel much better, they'd be okay, and they weren't any worse for the wear. But then what they did was they put down a barrier, and they would apply the shock to the side of the cage that the dog was in, and the dog would yelp and get upset, and it couldn't escape. And what they found was after a relatively brief period of time, the dog started to look depressed. They stopped having interest in their human handlers. Their appetite was disrupted. They stopped seeming to enjoy their food or wanting to eat. Their sleep became dysregulated in ways that looked very much like human depression. And this became the learned helplessness model of depression, the idea that we get depressed after our wishes have been thwarted just one time too many. Well, they thought they could use the same model to perhaps cure depression. So what they would do then is they would remove the barrier and they would apply the shock. And initially what happened was the dog simply lied there. It didn't do anything. They had to physically go in and pull the dog over to the other side and in essence show the dog that the other side wasn't electrified before the dog would come back to normal functioning. And this experiment actually became part of the evidence for the negativity bias, because it turned out that it was much easier to induce the depression-like state than it was to resolve it. You could do it with a few trials, get the dog to act depressed, but it took many, many times showing the dog that it could have self-efficacy, that it could get up and move before the dog would seem to recover. Now, mindfulness practice can help us with this by simply redirecting attention to the present and noticing that each moment is a workable moment for us. Because learned helplessness gets so much worse in a human than a dog because we develop a cognitive map for our circumstance. And that cognitive map includes the idea that my situation is hopeless and it'll never get better. If we look at the psychoanalytic understanding of depression, this also has validity to it. Freud famously said that suicide is like murder in the 180th degree. That what happens is we feel a lot of anger, often anger toward loved ones, but we don't feel we can express it, so it gets turned against the self, and that's why we wind up being filled with all this self-hatred, all these negative thoughts about ourselves when we're involved in a state of depression. So I want to tell you about my experience working with depression in the context of a meditation retreat. It's actually a state of depression that drove me to do my first intensive 2-week silent retreat. I'll give you the outline of the story. It was shortly after I graduated from college. There was me, there was my lovely, beautiful, warm, intelligent, caring girlfriend. And then there was her ex-boyfriend living on the West Coast. To make a long and complex story short, she wound up living on the West Coast, and I was not pleased. So even though I was a meditator, I was having a rough go of it. I was performing my jobs. I was working at a psychiatric treatment center at the time, and I was functioning okay. It wasn't a serious clinical depression, but I felt mopey. I wasn't really enjoying things. Life didn't have much taste to it. And I thought, mindfulness practice should help for this. It should help me to become more alive. I think I'll try going on a 2-week retreat. So I packed my bags and showed up at the meditation center. And there I learned about the structure of the day, which I've described to you before, in which you basically spend the full day being with experience. Doing sitting meditation, walking meditation, eating meditation. And the instruction was always pretty much the same. Once developing a certain degree of concentration, we move to open monitoring, and then whatever arises in consciousness, simply bring one's attention to what arises in consciousness. And I felt good. I have a plan of action. I'm going to do this. So I started with being with the breath, and some concentration developed, and it was nice. There was a sense of calmness and a kind of stability, and we were practicing noble silence, so we had the experience of solitude, but surrounded by others, so that it felt like a community. And then the movie started. And I could best describe these as alternating kind of romance and erotic films with slasher films. I would start to have images coming to my mind. I'm sitting there with my eyes closed, following the breath, and images of these delectable moments with my ex-girlfriend, complete with all sorts of physical arousal, and intense longings. How could I have lost her? How could I have her back? All of this is just coming up in waves, and I'm following the instructions. I'm simply trying to be like that Zen master who can be run through with a sword without blinking an eye, and just feeling it all. And then they would shift. They would shift into kind of slasher films, where I was seeing all sorts of horrible things that might befall my ex-girlfriend and the other guy. And they would alternate like this, but then periodically the films would stop and I would be with that ant on the stone wall, or I'd be watching the beautiful sunset, or really feeling the shower vividly. And my sense of the whole thing was, okay, there's a method. This is workable. And I remember at the end of the two-week retreat, riding home in the car and first thinking, wow, an interstate is a pretty intense experience when you're really opened up to it and feeling it. Just the sounds, the sights. And then I noticed I was definitely not depressed anymore. I felt longing, I felt anger, I felt sadness, I felt the exquisite enjoyment of nature, but I was definitely not depressed. I was alive. Here's what Bhante Guanarantana says. He's a Buddhist monk who's written about mindfulness. He says, you become sensitive to the actual experience of living, to how things actually feel. You do not sit around developing sublime thoughts about living. You live. So, how do we work with this in our meditation practice? How do we work with depression when it comes up? Well, we don't spend a lot of time talking about the why or investigating that or doing the narrative therapy that I described before. It's really about staying with what's happening right now and trying to be with or breathe into what's happening right now. And it's very similar to a number of experiential therapies, such as focusing by Eugene Gendlin, Gestalt therapy, or Peter Levine's somatic experiencing. Let me give you an idea of how this works with focusing, just as an example. Eugene Gendlin was a philosopher, and he was quite well known as an academic philosopher. He was doing well in the 1950s and the 1960s. And he came to the startling conclusion that academic philosophy is kind of abstract. And he thought there's got to be some practical use for this. And as it just so happened, he was working at the University of Chicago at the time, as was Carl Rogers, who we've discussed before as really the pioneer in describing how to cultivate therapy relationships. And Carl Rogers had collections of many, many audio tapes of psychotherapy sessions. So Gendlin teamed up with Rogers to try to identify which were those sessions that were most pivotal. And he found out that the pivotal sessions where people really came alive and really had a sense of transformation were sessions in which the patient or the client closed his or her eyes, went inside, paid attention to this part of the body, the core, not the distal parts like we were using for going for safety, but the inner feelings, and talked about them. Let me see if I can demonstrate that right now. I'm just going to be with the breath for a breath or two. And I can feel a little bit of pressure here, a little bit of pressure in the eyes. Maybe there's a little sadness, and times when I've done this recently, an image of my parents is coming up. My parents happen to be elderly and having a rough go of it on the West Coast. I could go deeper, but for our purposes, it's just a matter of noticing, now, call me a bad son, but I hadn't actually been thinking of my parents so far in recording this lecture. But all I need to do is connect in here, and it's back. So mindfulness practices, by helping us to come into the center and notice what's happening in the body, can actually connect us to feelings that might have been disavowed or pushed away. And in that way, they can help us to resolve the depression. So they help us to move toward the pain with the idea of asking, what do we experience in our body? What's our relationship to the pain? And can we feel compassionate with ourselves? Can we notice that this is painful, but as we discussed earlier with self-compassion exercises, to put our hand over our heart and comfort ourselves as we experience the pain. Now, mindfulness practices also help us to get a different perspective on thought. Because as we mentioned, one of the differences between sadness and depression is depression almost always has this narrative going through our mind. And it's almost always a narrative about how we failed, about how we're inadequate, about how nobody will love us, about how our life is hopeless. And this can sometimes lead to very absurd discussions in therapy. I found myself doing this as a therapist before, and my colleagues report the same thing, where our patient or client is basically laying out their depressive thought. And we're starting to argue with them and point out that, well, that's not really necessarily true. There are these options, there are those options. And our patient is becoming an even better debater. It's as though they're in a high school or college speech and debate club, and they're refuting every one of our arguments, convincing themselves with even greater certainty that their life is basically over. Now, we discussed before how in cognitive behavior therapy, the idea is to replace irrational and maladaptive thoughts with rational and adaptive ones. A mindfulness-oriented approach is different from that. It's about changing our relationship to all thinking, and this ultimately becomes more powerful. It's seeing that all thinking is unreliable. We can think of this as cognitive behavior therapy on steroids. One of the ways to look at the summary of changes in cognitive science that have occurred in the last 15 years or so. The big take-home point is we really can't trust our thoughts. Our thoughts are so influenced by our culture, by our history, by emotional biases of all sorts, that our thinking is really not to be trusted. And mindfulness practice helps us to have this kind of perspective on thought, which is quite helpful when those thoughts are thoughts of hopelessness and self-destructive thoughts. One of the ways to do this is to simply think about thinking. So when a thought arises, can we see the thought as just a thought? For example, instead of saying to ourselves, I'm no good, can we say, oh, there's the thought arising that I'm no good. It's a subtle difference, but it makes all the world of difference in how seriously we take the thoughts. Because when we see, oh, there it is again, as though the mind is a kind of neurological phenomenon generating the thought. The other thing that's very helpful is to practice moving below the level of thought to connect to the feelings and physical sensations that are beneath them. One way to work with this is by practicing what we might call affective or emotional meteorology. And this is really just another way of seeing the basic Buddhist principle that all things are impermanent. Everything is changing. It's all constant flux. And here's the exercise you can do. When feeling depressed, to simply inquire, when in the past did you not feel depressed? Most of us can remember a time like that. And then how were our thought patterns differently? How were our thought patterns different? This is very interesting. When we're depressed and we think about the time when we felt optimistic or positive about our lives, in the depressed state we think, oh, I was just fooling myself. I didn't see how bad things are. Now I see reality. And conversely, when we're in the state of mind where we're not feeling so depressed, we remember all the depressive thoughts and think, oh, that was just the depression talking. I saw everything negatively because of the depression. As we're mindful of these changing thought patterns, we see how radically unreliable they are. We see also that they change over time, that thoughts, mood, everything is in constant flux. And this tends to undercut the feeling that will last forever, which tends to keep us stuck. Now, it's very important to be able to enter the dark places. And this is true if we're helping somebody with depression or if we're depressed ourselves. We have to be able to fully feel our despair, our loneliness, our sense of unlovability, and our self-hate. And we have to learn not to fear these states, but simply see them as transient effects. If you recall the discussion we had earlier about being with my patient in the rather dilapidated room at Cambridge Hospital, she only started to feel better when I could really be with her in her despair. I have a favorite poster about this. It shows a dimly lit nature scene, and the caption is, "Despair. It's always darkest just before it goes pitch black." Because that's how it feels when we're depressed. It feels as though there's no darkest before the dawn. It's simply going downhill. So it's very important to know that it's possible to survive this despair. And it's also important to know that we won't kill people off with it. Very often when we're depressed, we feel toxic. We know people don't really want to be around us in this mood. The writer Andrew Solomon was author of a memoir called Noonday Demon, and it was really a memoir of depression. And here's what he said. You cannot draw a depressed person out of his misery with love. You can sometimes manage to join someone in the place where he resides. And this idea that connection is so important. It's interesting, when helping adolescents, for example, who are suicidal, one of the rituals I used to like to do, and other people do this as well, is to simply have the parents go around with the child around the house and collect those items that might be dangerous, that they might use to harm themselves. Because simply the act of doing that, the ritual, makes the child feel much more connected with his or her parents. I want to say a few words about hope, because hope can be tricky. Oftentimes, if we try to offer premature hope, either to ourselves or to somebody struggling with depression, it feels like an empathic failure because the hope feels to the depressed person like the other person doesn't understand. In fact, empathic connection itself offers much more hope. There are problems with hope. There have been a few studies that illustrate this. In one of them, they studied people who had colostomies. And colostomies are where they're removing elements of the colon because it's been diseased in some way. But sometimes they don't actually remove anything. They simply redirect things so that your waste products are going into a bag. So there are two kinds. There's the irreversible ones where they've removed a lot of the colon, or the potentially reversible ones where they're hoping that once the colon heals, they'll be able to connect the person up normally again. Guess which group of people feels better a month or two after the surgery? It's the people with the irreversible ones. Because the people with the reversible ones are every day waking up and thinking, oh gosh, I hope my colon feels better. I hope I'm going to recover. I hope I'm going to be able to get rid of this bag. Something similar is found among prisoners. Those who are sentenced to life without parole actually adjust better and are happier than those who are sentenced with very long sentences but have the option for parole. So we've got to be careful about this, about how much to try to offer hope to one another in these situations versus just staying with the experience in the moment, however challenging it might be. It's also important to try to find meaning, to ask ourselves, what's our heart's desire? What really matters to us in life? Acceptance and commitment therapy, or ACT, one of the mindfulness-based treatments, spends a lot of time on this, trying to find a way to clarify our values and find a compass for our lives. And this can give us a sense of a spiritual or psychological path. And then we don't see the pain so much as an obstacle, but as a developmental opportunity. This is really what happened to me when I was sitting on the retreat, and I saw the pain as something to work with, as part of a larger path to well-being, rather than just a problem. So I'd like to just say a word or two about medication, because you may be thinking, you're probably aware that medications are very often given to try to reduce depressive symptoms. And if the goal in treatment is not experiential avoidance, but to increase our capacity to be able to feel our feelings, then what might the role of the medication be? It does have a role. The diagnostic question to my mind is the person caught in a downward spiral? Is the depressed affect, the depressed emotion, leading to behavior which itself is resulting in more depression? Now this happens. You'll find somebody gets depressed and they start not calling their friends, or not showing up at work, or not studying for the test at school. And soon they're going to have a circumstance of being alone, or failing out of school, or getting fired, which itself is going to be depressive and depressing. So we want to, whenever possible, if somebody's involved in one of these downward spirals, to use anything that's going to help pull the person out, including medication. The goal here is to find the optimal level of challenge, not to dull feeling so much that we can't work with it, but not to be so overwhelmed that we get caught in this downward spiral. Now, nowadays in the United States, primary care physicians and other non-psychiatric healthcare providers prescribe over 80% of the antidepressants that are given. And they typically, on average, spend about 4.5 minutes before prescribing. It's not their fault, they're just very busy. So, automatically just going to take the antidepressant because we happen to be depressed and a doctor is suggesting it might not always be the best course of action. It probably makes the most sense to give this some thought, including to have some time to consult with a mental health professional to weigh out the pros and cons of this and to see how mindfulness practice might be used as an alternative or as a supplement. I'd like to end with a poem. This comes from Rumi, the Islamic poet from the 13th century who I mentioned earlier. And it really speaks to an attitude that we can have toward depression, which is a mindful attitude that can help bring us through it. It's called the guest house. This being human is a guest house. Every morning a new arrival. A joy, a depression, a meanness. Some momentary awareness comes as an unexpected visitor. Welcome and entertain them all, even if they're a crowd of sorrows, who violently sweep your house empty of its furniture. Still, treat each guest honorably. He may be clearing you out for some new delight. The dark thought, the shame, the malice, meet them at the door laughing and invite them in. Be grateful for whoever comes, because each has been sent as a guide from beyond. So in our next lecture, we're going to look at a close relative of depression that affects almost everybody to some degree, and that's worry and anxiety. Thanks for listening.